In the next slide or two of this presentation, we're going to discuss spirometry and uh, what roles spirometry plays in measuring lung volume and performance. I will say that I'm going to keep this particular presentation short because the video I posted for the AMP2 version of spirometry, where a lot of people, not all, but some people did a spirometry lab in that course. However, a lot of people did not do that lab and have never seen spirometry before. So really, that material is novel for a whole crowd of people. And so I don't need to go much beyond, I think, what we have in that AMP2 video. I'll be a little bit redundant here, but I'll try not to get, sort of say the same things twice. So you want to use that video as your sort of cover all the bases. I'll just hit a few things here. And one is this quick review of respirometry or spirometry. In the other video, I point out this woman is breathing into this old school. It's called a Collins respirometer. And just real briefly here, in case you haven't seen the other video, this is a bucket that's inverted inside of another bucket. Let me change my pen color. Because this bucket, this lower bucket, would have water in it, right? And so this stainless steel bucket is inverted in this bucket of water, essentially. And she's breathing into an airspace at the top of this upper bucket, right? So there's an airspace up here at the top of this bucket, right? That this hose that she's breathing into would come up, right? And into this space. And so as she breathes in and out of this airspace, right, the bucket is going to go up and down, right? Well, the bucket's attached to this pulley, right? I should point this out in the other video, right? It comes down here and it essentially draws the deflections of this drum based upon how much she's breathing, how much air she's breathing in and out of this Collins respirometer. And so we get this spirometry trace, which we have over here on the right. And what it shows is that when we are breathing normally, obviously we're moving relatively small volume of air, it's about half a liter at rest. That's called our tidal volume. But we can breathe in more than we normally can, right? As you breathe here normally, you can breathe in above and beyond that. That's your inspiratory reserve volume. You can breathe out more than you are normally, right? And so that's your expiratory reserve volume. That's essentially allowing us to increase our ventilatory volume anytime we have an increase in metabolism, right? And I think I did this in the other video as well, right? So the tidal volume is sort of sitting here. And again, if you don't breathe in maximally or exhale maximally, it would just sit here and go up and down all day long, moving half a liter every few seconds. But if we start to exercise, right, then our tidal volume can increase dramatically, and it can make a trace that starts to look more like this, right? And so the important thing, I'm just getting a little sloppy there, right? But the important thing to think, oops, I should have gone up here. Right? And so now my tidal volume is much bigger. So what I've done, though, is I'm using part of my inspiratory reserve and part of my expiratory reserve to increase my tidal volume. Again, getting more at the functionality than just measuring these volumes. Okay? So, so those are our three main volumes that when you add them together give us our vital capacity. And if you think about it, breathing in maximally and then breathing out maximally essentially would give us a measure of the maximum amount of air we could move in a single breath, which is known as our vital capacity. Right? Now, that is not your total lung volume or your total lung capacity. right, which is over here, which actually includes a volume of air that we cannot get out of you because your trachea doesn't collapse, and actually your alveoli don't collapse either, so there's residual volume there. That's actually where most of that residual volume is. It's called residual alveolar volume, right? So the residual volume actually equals the residual alveolar volume plus something called the dead space. Right? And the dead space is the volume of the conducting passages, the trachea and the bronchi. It's pretty small. I pointed this out when we were looking at the Weibull model. It's about 150 milliliters. This residual alveolar volume is much bigger, obviously about, oh, actually, I don't have numbers over here. That's fine. But the residual volume is usually about 1 liter, which means the residual alveolar volume is pretty big compared to the dead space. It has to be about 850 milliliters. Okay, and that, you know, and that air is one of the reasons it largely explains that dilution factor that we talked about with tidal breathing, right? When you, again, we'll get to this more in later slides, but you're breathing in air that has a PO2 of 160 millimeters of mercury, yet way down at the alveoli, it's only 100. Why is that? One of the main reasons is that every time you take in one of these tidal volume breaths, it's being diluted by all of this air, right? If we go from rest, all of this air in the system that's already had oxygen removed from it, right? So of course that's going to dilute the oxygen levels in that fresh air that we're breathing in. Last capacity I want to point out on here is this functional residual capacity. And you want to think of that as, yes, it's ERV plus the residual volume. That's how you get to that total. And actually, to point out another thing, capacities are simply adding separate volumes together, right? So anytime you're adding more than one of these specific volumes to another, you end up with a capacity. Okay, so what's the significance of functional residual capacity? There are others that I've left off this. Why did I not leave this one off? This is the air that your each breath of air is being diluted by, what I was just talking about, right? Because this expiratory reserve volume, if you're not actually exhaling it, right? In other words, if your exhalation ends here, right, breathing normally, then that breath, that 500 milliliters, is being diluted by all of this, right? It can be a 1 to 10 ratio. It can be that fresh air can be diluted by a factor of 10-fold, right? So again, that's a big reason that we have to increase our tidal volume when we need more oxygen delivery, right? Because of this dilution factor. We have to add more air, more oxygen specifically, to the alveolar volume, this, not the residual space, but the alveolar volume in total, to make sure that our alveolar PO2 is high enough to maintain our gradient, right? And so you really want to think about tidal volume being altered. Again, we'll talk about control of respiration later, but you want to think about tidal volume being altered to maintain the dilution factor that I was talking about here, either diluting a lot here or less, right? If we're breathing deeper, right, with this hyperpnic breathing with these bigger deviations here, right? Diluting a lot or diluting less, I wouldn't say little, but less, the incoming breath, right? Because if you're carrying oxygen away more rapidly from the lung surface, right, you want to increase our tidal volume and have a smaller dilution in this functional residual capacity. Okay. Now, actually, let me back up one. If we were to inhale maximally, right, and then, whoop, sorry about that. Well, we can do it on this slide. There we go. If we, right, so same trace, here we're breathing normally, then we inhale maximally, right, hold our breath for just a second, and then we exhale maximally and as forcefully as we can. We're going to move our entire vital capacity. But we no longer just call it vital capacity, we call it forced vital capacity, right? Because it's hyperpnic breathing, it's forced breathing, okay? And if we measure that over time, right, 1, 2, 3 seconds here, we can see how much of our vital capacity we can move in 1 second versus 2 seconds versus 3 seconds, right? And there are normal values, right? So FEV1, forced expiratory volume at 1 second, should be 80+%, right? If we would look at this volume as a fraction of the total vital capacity all the way to here, right? This will be about 80%. That's normal. Of course, out here at 3 seconds, we've moved the entire vital capacity, and so FEV3 over FVC would be 100%. FEV2, right, we have a little ways to go right here, right? Can't get my line straight, right? But a little ways to go here, and so FEV2 would be probably 95, 96%, something like that. Okay, well, what is that useful for? Well, now we can put together measurement of the lung volumes and then measurement of this sort of lung performance that we get if we try to move the air as quickly as possible, your vital capacity as quickly as possible. And again, this is a lot redundant with the previous video. But if you invert this section of the trace right here, this downward sloping component, right? Just invert it. Right now it's expired volume going up in volume. Here it was going down in volume. So we've just taken this section and flipped it essentially over time. We end up with our normal trace, right? Here's our 80%, right? That means that this value would be 80% of that value, right? That's our forced vital. This would be FVC, again, which also equals VC, right? Just because it's forced does not mean you change your vital capacity. It just means you're doing it as quickly as, moving it as quickly as possible. If you have respiratory diseases, then we change our lung performance. Well, respiratory diseases come in 2 main categories. Obstructive diseases, right? COPDs, over obstructive, right? Chronic obstructive pulmonary diseases, and restrictive diseases, chronic restrictive pulmonary diseases. What we find about obstructive diseases is they obstruct airflow, and so they make it harder to move the air quickly. And of course, our line will have a lower slope here, right? And which means, of course, that we move a lot less air in 1 second than we do under normal circumstances. And you get an FEV1% of FVC, much less than 70%, right? That would be an indicator of COPD. Now, COPDs, they are changing performance only if they are exclusively obstructive, right? They tend, if they are only obstructive, here's a good example. Asthma it's not a chronic disease, it's an acute disease, acute onset, right? So it's not a COPD. But it has similar effects in that it increases obstruction of airflow, right? It does not diminish the amount of air a person can move. They just can't move air fast enough to ventilate well enough, right? And so these people are gasping, trying to sort of move enough air, okay? Now, in restrictive diseases, right, now we've got, again, go to the other video for more details, but we get things like scarring of the lungs due to things like asbestos, breathing asbestos particulates over time, or people that worked in coal mines, right? All that particulate matter causes scarring of the lungs and reduces their elasticity, right? And so what it's doing is it's changing the compliance, right? If we decrease our vital capacity, right? In other words, our vital capacity normally was way up here, right? And now it's way down here, right? We've decreased the elasticity of our lungs. They become more rigid, and so they don't inflate as well and as much, right? And there are several factors that will induce a loss of elasticity. or a decrease in compliance for other reasons, right? In other words, elasticity is only one of them. So fibrosis would be one reason to lose elasticity and therefore reduce compliance. Another reason for reduced compliance would be, and again, it's not a CRPD, but it would result in reduced compliance, and that would be surfactant, right? The decrease in surfactant. Try to tie a couple new things into this, right? Decreasing surfactant. Well, surfactant broke up the surface tension in the alveoli. Go back a couple slides, right? We tie that into Laplace's law, right? Which basically said that the transmural, we call it the collapse pressure, P, equals the surface tension divided by the radius of the pipe that we're, the bronchiole that we're running it through. And so in our small bronchioles, when we lack surfactant, and again, this is usually in premature infants, we end up with a disease called infant respiratory distress syndrome. And because of this, the surface tension, right, is changed because of the lack of surfactant. And it affects the small bronchioles because in the small bronchioles, right, this is very small. The radius is very small. And so if T is big and the radius is very small, then our transmural across the wall pressure, we call it the collapse pressure, becomes very high. And it tends to make these small bronchioles collapse, right? And of course, that reduces compliance, the ease with which we can ventilate the lungs, and make it difficult to both, it's actually a bit obstructive and restrictive, as we see with an arrow like this, with our COPDs often having both obstructive and restrictive effects. But anyway, so it's that loss of surfactant and an increase in surface tension becomes an impediment to air movement, and can even also become restrictive in terms of actually reducing the maximum degree of ventilation of the lungs, because these air spaces become closed off and no longer are contributing to the functional lung volume. Okay, let's see. I wanted to point out one other thing. Well, let me review just for a second here, right? So our COPDs are things like emphysema. I want to come back to that for a second, or chronic bronchitis. They're tending, usually because of a increase in mucus production, we get this sort of obstructive factor in the small bronchioles. Again, in the restrictive diseases, we have the ones that sort of make the lungs more rigid. Or another one I pointed out in the other video was arthritis. It makes it harder to fully elevate the ribs. Again, reducing the ability to maximally change the thoracic and therefore lung volume. Okay. Now, one of the things I wanted to point out relative to our previous slide, previous picture, was what happens in COPD with regard to a couple of things. One is that we lose elastic tissue in emphysema. And so what happens is the lungs sort of like remember the lung recoil was a major factor in sort of pulling, helping with passive exhalation, but also creating that negative interpleural pressure, right? So what happens is instead, let me go to separate view here. So instead of, let's say if this is our normal trace, right? We have our inspiratory reserve volume, go back to tidal volume. And again, the shape of this trace is entirely determined by how you're breathing, right? This is just, I'm going to go with a consistent pattern of breathing here. If you're exercising, right, it went from, this is sort of a normal pattern, of breathing normally and then inhaling maximally, then exhaling maximally. If you're exercising, let's say you stop exercising for just a second and do the exact same thing, the trace will look a lot more like this. Try to get the match up, sort of. Right, where we've used some of our inspiratory reserve and our expiratory reserve, right? We increased our tidal volume, right? Again, basically to change the ratio of fresh air to our functional residual capacity that we're mixing it with each breath, all right? And then if we were to go one more and say, okay, so this is exercise, sorry. Label these. Let's say this is rest. This is exercise, right? Or immediately after exercise when your tidal volume is elevated, right? And then let's go to COPD, right? Emphysema. And now this person can breathe normally, right? What changed here? Right? Well, what changed was the tidal volume is no longer, it's not in the middle up here. IRV and ERV are not equal. And they kind of look equal here, but they're not. But it's kind of in the middle, right? Well, what happened was I just shifted the tidal volume into the upper range of our functional lung volumes here, right? In other words, the tidal volume is you're moving air up and down, but you just shrank your IRV, right? This is your IRV here to here, and so you no longer inhale so dramatically when you're trying to, right? So this is called hyperinflation. And remember, what do they say about emphysema? It causes a loss of elastic tissue, which means the lungs are constant, which would tend to compress the lungs normally, right? Well, this is one of the reasons why exercise is really uncomfortable for someone with COPD, because the lungs are hyperinflated at any given moment because of the loss of elastic tissue, and then because of that, they tend to hold a larger volume at any given moment, right? They can still exhale, right? Their vital capacity isn't necessarily shrunken, although remember over time it can. But at least early on it isn't, and so their IRV shrinks. They have this hyperinflated lung, and it's kind of uncomfortable to breathe because you can't really breathe in more than you already are, or at least a lot more. Okay, so that's one of the downsides of COPD. Another big downside to COPD, which is unrelated to this, is that breakdown of elastic tissue, breakdown of connective tissues in general, decreases surface area. Right? You should immediately be thinking decrease in JDIF. Right? The big problem, yes, it's uncomfortable to exercise over here. The big problem with chronic emphysema is a loss of surface area, which decreases our diffusion rate because surface area is directly proportional to JDIF. And of course, you limit your oxygen uptake if you're not diffusing well. And so oftentimes we have to compensate by having them breathe higher air with a higher O2 content, right? They're breathing this out of a canister essentially with a nose cannula so that they can compensate by increasing the concentration gradient. Good test questions, right? We lost surface area. How do you compensate to make sure that they're getting decent diffusion? Well, one of the few things that you can tweak in the Fick equation is the concentration gradient, because you can increase the concentration of oxygen in the air that they're breathing. Okay, A fair amount of redundancy there with the spirometry, the previous spirometry video. I apologize for that, but I did want to layer in a few other things on top of it, and wasn't sure how to separate the new from the old entirely. So, on to the next.